filtering in. But yeah, thank you for joining us today. This week or this month for our MapNet seminar, um, we really wanted to focus on a topic that I think has been having a lot of discussion psychedelics, and specifically for the folks in our network who work with young people experiencing early psychosis, and in the Massachusetts context of this being on the ballot last November, not passing, but still being something that folks are very much talking about. We wanted to bring in some experts from various areas, both within the field of psychedelics and in the field of early psychosis, to kind of talk about what the current research is, what we should be thinking about, and how we should be talking about this stuff. Dr. Keshavan is our moderator today, and he will be doing the introductions for all of the panelists. But then, yeah, we can get started. So yeah, thanks everyone for.
Okay. All right. Thank you, Kelsey, and good morning, everyone. Um, Really, I am privileged to be the moderator for this morning's discussion on a topic for which I claim no expertise myself. But given that we are discussing this topic of psychedelics in the context of taking care of people in the early course of psychosis, I thought that I would be in a good position to ask the relevant questions to this group of experts that we have assembled here today on different aspects of psychedelics as we know it. The reason psychedelics might be of particular relevance to psychosis is because the very first name that was used for this group of substances was that they were psychotomimetic or psychotogenic, which was kind of the earlier name before the term psychedelics was introduced somewhere in the 1950s and 60s. I understand with people like Osmond from Canada uh, and others from the US who were early in this area of work. And so the key questions that we as a group would like to understand is, first of all, the historical and current uses of psychedelic substances and their potential risks and benefits, and approaches to discussing their use in individuals in the early course of psychosis. Secondly, we also want to understand how we can respond to someone who is experiencing an early course of psychosis if they say they are thinking about taking a psychedelic um, out of either curiosity or a belief that it might help them, or for cultural reasons and so forth. We also want to understand how psychedelics are emerging as potential therapeutic agents in the field of psychopharmacology, where really there has been a major need for new medications. We haven't had over the last half a century any new major classes of medications. And how do we understand the relationship between psychedelics and psychosis, and what are the implications of recent efforts to legalize recreational use of psychedelics in Massachusetts and the rest of the country? So those are the main goals of our session this morning. And so the structure of how we want to do this is I will first give a brief introduction to all of our panelists, and then I'll have each of the panelists spend a few minutes telling us their perspective, how they came to this field, and how they got interested, and what their experience and vision is, and so on. And then I will take the discussion through a number of questions that I just raised. So with that, let me briefly give you an overview of the wonderful panelists that we have assembled. Three of them psychiatrists, and one of them an expert in the use of psychedelic medications from a from the perspective of traditional medicine, and one person with a lived experience of psychosis. So, first is Raul Kandamarin, who is a practicing physician and psychiatrist at Massachusetts Mental Health Center, where I sit, um, and at the Beth Israel Deaconess Medical Center. He takes care of patients, but as well as teaches child and adolescent psychiatry at Harvard, Tufts, and Brigham. His fields of expertise include cultural psychiatry, metabolic syndrome, psychopharmacology, psychoanalysis, and psychosomatic medicine. So virtually is a master of multiple trades. Um, Darlene Flores is the owner of Karaya Wellness Clinic at Brookline, Massachusetts. She's a traditional medicine keeper for her Caribbean tribe, which is called I hope I'll spell it right, pronounce it right, Higuayagua. Correct me if I'm wrong, Darlene. Caribbean tribe. Um, Dr. Flores is a highly decorated U.S. veteran. She's a chiropractor while in the army. She's a got a and she has a PhD in chiropractic college from California. She continues her work as work of her family. She was born to Boricua parents and was raised in the metro area of Massachusetts. She practices as a holistic Husero, bone setter, and holistic energy worker to treat patients of all ages and walks of life. Ryan Henner is a psychiatrist at BIDMC. He also is a psychopharmacologist and also practices treatment with psychedelics. And he has years of experience in consultation liaison psychiatry and runs the Harvard affiliated esketamine clinic in Boston. He got his medical degree from Medical College of Georgia and residency at the Harvard Longwood program, and including training both at BIDMC and Brigham. Dr. Hyun Young Kim is a child psychiatrist, child and adolescent psychiatrist. She focuses on early psychosis, especially developmentally informed care for youth at risk for psychosis, also known as clinical high risk for psychosis. She's particularly interested in investigating the association between psychedelics and psychosis in CHR, or high risk youth, and then translating her work into educational outreach. Um, she co founded the STAR program, which is the Service for Clinical High Risk Individuals in McLean Hospital, where she's the Director of Psychiatric Training and Research. And Vera Muniz Saur is a Peruvian public health professional with mixed Spanish and Andean ancestry. He works as a program coordinator and peer advocate at BIDMC and as a peer counselor at McLean's Leap Center. Vera has a schizoaffective disorder. He is a survivor of conversion therapy targeting sexuality and identifies as a psychiatric survivor. He graduated with a Bachelor of Arts in Psychology and a Master of Public Health from Boston University. So, with that as the background, let me quickly turn to each of the panelists to tell us about their journey as to how they got interested in this field of work. And then that would kind of be a nice background for us to get into the specific questions. Thank you. Maybe I will first turn, as I see on my panel here, have Vera first at the top. Vera, you want to go?
Yeah, for sure. Hi, y'all. My name is Vera Muñiz Torre. I use they, them pronouns. I am from Beth Israel Deaconess Medical Center as a project coordinator, but I also work at McLean as a project manager. I am a public health professional that has worked in Boston probably for the last, I would say like 8 years in the public health realm, but I've lived here for like 10. I start mostly working in HIV prevention services and substance use prevention services, mostly working through a harm reduction based lens. And I've worked primarily through the Latin American, I work through Casa Esperanza, which is a Latin American focused mental health agency in Roxbury, serving primarily the Black and Brown youth of this area, through an education based program that I largely modified to be more focused on harm reduction. I currently work now as a peer specialist and project manager at McLean, largely uh, connecting a lot of services through also my work on the Massachusetts Psychosis Prevention Partnership, which is in collaboration with Beth Israel, connecting a lot of these larger networks of peer service providers and peer workforce folks across different clinics and different community-based organizations. So a lot of my work that I want to go into going forward is in like meaningful participatory design and making sure that the people who are taking part in a lot of the interventions that we are using in a lot of our clinics and practices are the ones who are able to affect those practices to be able to make sure they're actually being equitably distributed, as well as that these treatment modalities actually have some level of like actual efficacy. And largely doing that through like research in implementation science. So in the ways in which that we report on, create, and operationalize our scientific methods. But I'm happy to be here. I'm also a Peruvian person. I am of mixed Spanish and Andean ancestry, and a lot of my journey in terms of psychedelics has been reconnecting with like traditional forms of medicine, talking and connecting to local indigenous communities from people all over. And also from a more recreational standpoint, I've supported many youth and community members who have experience using psychedelics. I have my own experiences, and largely I have a lot of connection through historical and social movements and grassroots organizing. So I have a relatively in detail background in terms of researching like things like the CIA and using like psychedelics as government experiments, and also looking into the history of our abolitionist as well as our prohibition movements in the United States, starting from like even back with I forgot her name, but like and like thinking about like cannabis prohibition in the United States and the ways that that was largely a racialized movement, as well as how prohibition in general for alcohol was also largely tied to that sort of racialization and classism. But happy to be here. Thank y'all for the space, and I will pass it off to Darlene.
Darlene?
Usakasakabo abatoma, da irilea dahiabo, da traha taino lankairi borinquen. Good day, everybody. My name is Dr. Darlene Flores. I am a Taino Boricua Native American woman from the island of Borinquen, currently known as Puerto Rico. I currently reside on the lands of the Eastern Woodland tribes here in the state of Massachusetts. I am a medicine keeper for my Taino Higuayagua of the Caribbean tribe, which encompasses a variety of things in our community. One of them being a facilitator for our sacred medicine ceremonies. And one of the medicine ceremonies includes the use of yopo, which is also known as cojoba or tobacco, which was misnamed in the early 1500s. The medicine does include DMT in various forms, and I'm happy to be here. I do a lot of work in the indigenous community, not only in the Taino communities, but I'm an activist here in the state of Massachusetts, and I run and facilitate, I coordinate a lot of different cultural events here in the state. We're changing laws regarding the Indigenous Peoples Day and bringing more voices and more opportunities for non-Indigenous people to bridge the gap with Indigenous folks and trying to create community and unity everywhere we go. Thank you for being here, for allowing me to be here.
Yeah. Thank you, Darlene. Ryan, do you want to take it next?
Sure. So yeah, I'm Ryan Henner. I came to this work really through a pretty intensive period of exploration in yoga and meditation across really across disciplines, I would say. And when I say disciplines, I mean exploration of the groundwork of meditation through Buddhist ideology, Hindu ideology, mystics of various ilk. And then I kind of became aware of the potential resurgence of psychedelic use in psychiatry and pivoted from an intention to go into child neurology, into psychiatry, and find myself here now. So, when I talk about psychedelics, the way I get my foot in the door in the medical community is talk about the neuroscience of it. So I know a fair amount about the neuroscience of psychedelics, and I'm happy to share some of that knowledge with y'all. But what really I find most interesting is the subjective experience of psychedelics and the potential for perspective change. Both in the potentially therapeutic as well as uh, in a way that carries some risks for people who are not ripe for such experiences. So that leads me to talk about both kind of ego levels of experience using kind of a psychological language as well as spiritual experience and practices that are utilized in order to explore those realms of consciousness other than taking psychedelics. So it's kind of a wide-ranging interest, and I'm looking forward to thinking with you all about these.
Thank you, Ryan. So, Rahul, do you want to go next? You're muted, I think, still.
Do you hear me?
Yeah, now we can hear
Okay.
you.
No, once again, thank you so much for the invitation, Kesh. A very interesting topic and rich panel. The way I got in here with the psychedelic and drugs is basically I am Peruvian, as Vera. I am Peruvian, and I did my first training was in chemistry, and then while in Peru, was working for a little bit with my sister, who was also a chemist. All of my brothers are chemists, so I was working in the field for a little bit. So I always was much easier for me to see this new medication, new things in terms of more chemistry way. Then I did internal medicine, but I remember now that I could be just 8, 10 years old, and we hear that people want to be taken to a special person, no, who do ceremonies at night, and they came and they feel better. Or when the doctors apparently cannot solve the problems, they go there. So it's something like it's a little high in the cultures, at least in Peru, Ecuador, Bolivia, and other places, but it's ancient. But people know that exists, no? And people go and they, I think, have more favorable things regarding this kind of treatment. In the case of Peru, was basically with ayahuasca, was a kind of similar with psilocybin, with a little changes. The second encounter with this is when I was doing general medicine, internal medicine, people mentioned this, no? I went to see the person, I feel better, I improve, no? I think one of the important things about this is like, apart for now, the psychedelic are very promising for depression, for anxiety, for OCD, for substance abuse, for so many things. One of the questions probably we can discuss later is that is really true, too good for everything? Or there is the root of the problem is this, and the manifestation is through anxiety, to depression, to OCD, to this, to psychosis. And by taking the root, we improve, not cure, but they feel better. Now, that is my approach to this, my desire to know a little more, and also probably, as Vera, trying to, and Darlene, connected with my culture. Thank you.
Thank you, Rahul. Last but not least, Dr. Kim.
Hi, I'm Hyun Kim. As Ketchula mentioned earlier, I primarily work with adolescents and young adults who are at risk for developing psychotic disorders, also known as the clinical high risk for psychosis. So my initial interest in psychedelics, it didn't have much to do with my professional work. I was very much into like exploring different kinds of the meditation practice back then. And I was learning about and trying different meditation techniques and also learning about like different states of consciousness. That is sort of my starting journey. And then that's when I got to learn about psychedelics. I read some of the very popular books out there that a lot of the, some of you guys might have read. I found it really fascinating, very intriguing. And it really started to follow the literature of different kinds and going to attending conferences and webinars. And then one day there was one webinar, which was regional actually in Boston, when the guest speaker was the Massachusetts House representative who was working on the ballot initiative for psychedelics back then. So we had a chance to view the working documents of her group was working on, and also had a chance to have some Q&As and discussion about different aspects of the process. I must say that evening, that seminar, that webinar was sort of very much eye-opening and experience, and actually became a turning point for me in terms of my involvement in this psychedelic space. There were two things that I got to realize. One was the fact that there seems like it felt like there was a great imbalance between the amount of attention that was given about the potential sort of benefit of this whole movement and these compounds versus what are the kind of potential sort of the adverse outcomes or risk management aspect that we need to think about. And then the other part that really that I felt really shaken by during that discussion was like how much significant gap was there between the knowledge base and wisdom that we already have, informed by the historical facts as well as the research findings, versus how the public and policymakers are perceiving it, interpreting it, and just sort of running with it. So with that, I became more, my interest became more focused on understanding the relationship between psychedelic use and psychosis, and also hopefully with more of understanding, being able to share that knowledge with the non-medical communities through science communication, because I felt like that was a big missing part in this whole movement. So I'm glad I'm here today and looking forward to more discussion.
Thank you very much, Kim. So with that as the background of all the panelists, what I would like to do next is to kind of raise a number of potential questions of interest to this audience. And I'll ask one of you to take the lead in addressing each of those questions, and all others can jump in after that as well, because you all bring different perspectives on the same topic. So first of all, it's useful to know what psychedelics are and what do they do to the brains. And Dr. Henner, you mentioned that your interest has been in the neuroscientific background of this, and I know you and I have written a paper together on this fascinating topic. So I'd like you to give this group a kind of a thumbnail sketch as to what we know as to what these drugs do to the brain, not only from the point of view of neurotransmitters, but also in terms of neural circuitries. There has been a really lot of exciting work in this area recently, as you know.
Excellent, sure. So, from a neurobiological molecular perspective, the classical quote unquote psychedelics, such as, for instance, psilocybin, looks like I'm getting some background noise, such as psilocybin, LSD, and so forth, are 5-HT2A agonists. And so, they're serotonin agonists specifically at the 2A receptor, though there are a number of substances that are grouped in the category of psychedelics that have, perhaps some 5-HT2A agonism, but also do other things. So, you'll hear about ketamine under this umbrella, MDMA or methylene dioxy methamphetamine, and cannabis has some psychedelic effects, and so there's been uncertainty about what do you mean when you say psychedelic? And when a few years ago I was using a very a, how to say a taxonomy in order to describe it. I was talking about shared subjective experiences, including, for instance, uh, a dissociation of, the psychological ego, dissociation perhaps from the body. There are a lot of different experiences that kind of come under this psychedelic umbrella. And as we have learned more about the effects of drugs with these psychedelic properties on a neural network level, we are starting to see that there are some real patterns emerging. And in particular, what we're seeing is a disintegration of the canonical brain networks, such as, for instance, the default mode network, right? So the default mode network is commonly described as what your brain looks like when you're not, quote, doing anything. So it's associated with autobiographical memories. It's kind of what you're doing when you're hanging out is the default mode network. And so the default mode network shows aberrations across a wide variety of psychiatric illnesses, including especially an overly rigid quality in our neurotic illnesses, such as depression, anxiety, and so there is a model that is being kind of increasingly adopted in the psychedelic space, really spearheaded by a guy named Robin Carhart Harris. So he's worked with labs, across the world in advancing this idea of relaxed beliefs under psychedelics, where you take a psychedelic and the brain develops a really kind of a diffuse activation pattern. So rather than having these really clearly defined brain networks that are humming along synchronously, that there is this desynchronization of these networks, and you see more of a diffuse or hot entropic kind of brain activation. And so, the thought is that with this quality of brain activation, that one can reduce the top-down or kind of cognitive models that you're imposing on your moment-to-moment experience. So I'm depressed. I'm always going to be depressed. New stimuli is interpreted with the lens of depression. And instead, when you drop some of the rigidity in those brain networks, incoming stimuli can be interpreted in a new way. And so your beliefs are relaxed and you're able to kind of change the way you see and experience the world. I did a little bit of homework before this panel, and I noticed that one of the clear patterns in neural network activity at rest among people with psychotic illness is, while they don't highlight the same brain regions as being kind of less tightly regulated, but nonetheless, this idea of decreased synchronous activity is one of the core patterns that we're seeing on fMRI among people with psychosis. So it's unclear what that means for those folks who take psychedelics, for the reason that we have not yet seen any sort of randomized controlled trials where folks with psychotic illness take psychedelics due to this kind of collective worry that it could worsen the illness, but it seems plausible that if given a drug that exacerbates this pattern of increased entropy and disintegration, that it would kind of further the brain changes that we're seeing among people with psychosis. So those are kind of some opening thoughts in terms of the mechanism.
I think that's particularly really interesting what you bring up about the default mode network, because I know classically the default mode network is sort of conceptualized as like being really associated with like flow states and like doing activities that are not necessarily like taking all of your attention. And I think that largely dissociation is something that's also largely implicated through the default mode network. And I think that that's particularly interesting because when brought up with in conjunction with like what you bring up about like how does this sort of disintegration of existing like neural systems, like different parts of the brain that are not able to, or that normally operate asynchronously or not necessarily in direct connection with each other, creating new connections in between different neural systems that may not necessarily be there when somebody's not using a substance. I do think of that as being something that could potentially be a catalyzing factor in somebody who's experiencing psychosis for the first time, especially when we're thinking about like first episodes. And also I'm thinking about the ways in which like historically when we're thinking about, I brought this up in my intro, like the CIA's like MK Ultra experiments in the 70s in which they had like many people who were like unethically experimented on with psychedelics as a way of to try to develop some form of interrogation tactics. What was found is that participants in a lot of those unethical trials who experienced schizophrenia saw a lot of relief from their negative symptoms as a result of microdosing on psychedelics. So I think that's something else to think about is that, like, yes, when we think about psychosis and psychedelics and schizophrenia, we're thinking of like this hyperactivation of neural networks, particularly of perceptual networks. But I think it's also important to keep in mind that like schizophrenia is not just an overactivation of the brain. There's also like aspects of neural functioning that are either atrophying or like maybe seeing some level of effect as a result of somebody's own circumstances. And all of those things can also be made worse by having an unstimulating environment, living in a place with a lot of pollution, and generally living with a lot of socioeconomic stressors. So I think that's also important to think about is that like these neurobiological mechanisms are important to understand. And also like if we only look at the neurobiological mechanisms outside of context, we're not really understanding what they actually mean.
Yeah, thank you. Those are very thoughtful remarks. Others on the panel with comments on this topic?
Yeah, I would like to just to to add it a little bit in the comment of Ryan and Vera. This is a reference of an article I read who was published years ago in Spanish for a doctor in Peru who was in the emergency room and came somebody who was really paranoid. No, the client wasn't a 40 years old or so, entrepreneur, 25-year history of being working, but 2 days before or so, he was in a retreat for ayahuasca in the forest of Peru, no? And so they realized was related to that. But the main thing, he was very psychotic, very paranoid. He still hallucinated, no longer with nausea and vomited, but very dissociated, really psychotic. But the family mentioned there was no history of psychosis in him and the near family. Years then later, they found that there was a distant history, somebody in the family, distant history of psychosis. That made me think about like, with this retreat, the amount, when we're doing the research in here with psilocybin, is usually a dose of 25 milligrams. It's exact milligram people doing this. With the ayahuasca, for instance, it's difficult to measure, no, the amount. Of course, they call shamans, they know how to do in the amount, or if they know the needs are more, they give a little more. But one of the questions could be in terms for everybody, including you, Kesh, is if people with even long, not too close family history of psychosis, did they have more hypersensitivity to activation because the psilocybin, the psychedelic activate mostly the 2A, serotonin, but also 1A, also dopamine, also there is a way to increase the glutamate. No, I don't know if that could be one of the reasons for people who have that predisposition. In this case, because I mentioned this case because it's nothing like the father or the mother was with psychosis. No, was very distant. But and in this case, according to this report, took like a couple of months for this person to go back, from this state of psychosis. So I think it's a lot more involved receptors. The entropy increase is the more asynchronic activation. All this mentioned for the panel before.
Yeah, I have some thoughts, but before I say those, I'd like to hear from Dr. Flores and Dr. Kim.
Absolutely. Obviously, I'm not a neuroscience, so I can't tell you the part of the brain that is being activated with these different medicines that we're using and when you guys use them in terms of drugs, right? So I do know that some of the medicine ceremonies that I deal with, they're heart or openers, meaning that they give a sense of love, right? And not only self-love, but love for everyone around you, including the earth and the trees and all the things that encompasses what we consider in our ceremonial circles. But I have noticed, and it has come when you have someone who has participated in these ceremonies, that the brain does rewire the brain. And I don't know what are the neural pathways or what they're called, but if they participate in other ceremonies after the initial, it seems it's easier for them to get to that state because versus the first time, it might take a little bit more coaching. It might take a little bit longer for them to get there. And then a second time, if they do a ceremony a second day, the neural pathways are already there. So it's easier for them to get there. And it might be something else. It might be they participated now instead of a Cahoba ceremony, a Yopa ceremony, they're using stuff as something simple as a marijuana. And so with marijuana or psilocybin, it seems like they go into that state faster than they would if they just have done straight marijuana or straight psilocybin. And I've noticed the rewiring of the brain. Setting is super important when it comes to the actual ceremony, and for them to feel, comfortable to participate in the actual ceremony itself versus in, a setting where you're in an office and you're sitting down with one person. I think that there is a sense of taking away the communal aspect of the actual journey, right? And having people who have participated and experienced those states actually assists the person as well when they're going through their journey and having these medicine ceremonies. As far as the aspect of the rewiring, I don't know the other, that you guys talked about the ketamines and the other drugs that you guys are experimenting in, the LSDs and stuff like that. I don't know if those particular drugs do the same thing, right? So I can only say for the things that I facilitated in, and I say the things that we do are more heart openers, right? And setting means a lot. And so I think it's very important when you're treating patients that, that lack of understanding of what they're experiencing. If you don't understand what they're experiencing, how are you going to facilitate them? And if they end up, as some people say, are a bad trip, or they're not feeling well, they're feeling more anxious in the moment, how are you as the facilitator, the therapist, able to have a rapport with them and then make them feel safe, right? Those are my concerns when it comes to, okay, I know here in Massachusetts, the law came up about let's try to get this passed. A lot of people don't know about the effects and what it doesn't do. And so just like when marijuana was first brought up, there was a lot of resistance. So I think there needs to be a lot more education, not only to the public, but the therapists as well, on, their responsibility and maintaining, the authenticity of what we're trying to achieve. Right. And I also believe, just as, excuse me if I'm saying his name wrong, Dr. Raul Condemarin.
Yeah.
So for me, there is a DNA, and for me, DNA does have memory, right? And so for someone who is experiencing, what you might call psychosis, you know what I'm saying? There is an aspect of down the line, just like you say, in the DNA, there is a memory of it, and so maybe they might have, just smoked the marijuana just that one day, and then it brought them back to that state where in normal terms, everyone's like, oh, they're having a psychotic break, right? Because that's normal right now to everybody else. But what if it was that in their DNA already from generations to generations, their lineage is that they've used these sacred medicines and ceremonies, however long, and now it skips these generations and they go to smoke a marijuana or do something small like that. And then all of a sudden they're in this heightened state and they're confused because they don't know. And they're around people that say that's not normal, And that's another important aspect to bring in, that, in the DNA, we do carry memory, and then carry memory of the medicine. And so, and the wanting to be in community where people understand that is super important.
Okay, thank you very much for those really thoughtful comments. Dr. Kim, do you have any thoughts before I?
Yeah, I have a lot of thoughts actually, but like I'm trying to make up my mind which one would be most useful to discuss. But something that I've been thinking about a lot recently is that this notion of a heterogeneity. Because we are even for schizophrenia, this is like sort of in a sense arbitrary kind of diagnosis, based on DSM criteria. But we all understand there is so much that individual variation, and then different types of like a phenotype, all that kind of stuff, right? And as I mentioned, yes, I've been looking into and then reading about the research findings around psychedelic use or hallucination use and psychosis risk. And as you just learn about it more, it feels like it's a very messy. But I think a part of the reason is because we are really the state of science at the moment we are at is like we are really just like a kind of scratching the surface at the very, very global level that may not be able to reveal anything like useful. I'm not saying that that is the case, but at least so far, that's kind of the way it feels like. But if you look at that individual, like that, counting that heterogeneity, and then how some of the individual vulnerabilities, or like on the other end, the strength factors, they play out, and then look at things at a more granular level, actually there are some meaningful findings out there speaking to some of the significant association, including the recent paper that came out from JAMA. So that's one thing that I wanted to bring up, and also it kind of comes down to the matter of the like really the question about like a psychedelics. What does that mean to early psychosis care? It applies there as to that question as well. I'm being really cautious about talking about it because, as I said, something that I noticed, from some other conferences or webinars was that, like, okay, like this is the professionals or somebody, make some kind of statement, and how that's being perceived by some of other attendants. Like I do not want to be misunderstood by saying this, but what I've been thinking about is, well, like personally, I've been more focused on the risk association. But on the other hand, yes, it is true that in the field, primarily within psychedelic research community, there has been very, very cautious speculative hypothesis that's been proposed that, you know what, maybe these individuals we've been excluding from all of these trials because they understand that there's a level of concerns about its potential impact on psychosis, for especially for those who already have pre-existing conditions and diagnosis. And yet we are not there. But research-wise, maybe we need to look into that possibility. Maybe there might be some potential utility these compounds hold for, especially for those areas that we are facing great challenges, such as negative symptoms or cognitive impairment issues, which tend to be, really like a part of a great burden of the illness, especially when we are thinking about quality of life for these individuals, right? As I said, this question is like very much speculative kind of a level, like research wise. It's nowhere close to like a clinical application. So say like my patient come in, already had a first episode of psychosis or has existing years of condition of schizophrenia, ask this question like, can I try or can I do microdosing? Then my bottom line answer would be no. We are not there yet, and with explanation, and yet we cannot really wipe out that possibility because how these compound works for somebody may not be the same for the other subgroup, even under the sustained DSM diagnosis, because everybody's different, and then there are multiple different ways of these medications, these medicine or compounds work, and things about. Again, very, very speculative, but like things may work out differently for a certain subgroup versus the others. So that was the one thought that came up my mind.
We'll come back
And
to some of those thoughts again
Yeah.
in a later
Yeah.
question, especially what you said of the heterogeneity. And when patients ask us, can I use it? And then what should be our answer? And what you point out is that the answer is not simple. It depends. It depends on the individual, right? So for this audience, I want to kind of, since you have heard terms like the default mode network and what it might mean, what does it do in the brain and so on. Let me take a slight detour here and share a picture. If people can see this, can people see the slide I'm showing? So this is the brain.
Yeah, now it's up.
The top panel is the inner side of the brain, and the bottom is the outer side. So there are some regions in the inner side of the brain, like what we call the posterior cingulate cortex and the medial prefrontal cortex, which basically like the brain turned inward. When you're not doing anything else, when you're resting, your mind wanders into the future or the past or about yourself, about the latest gossip and things like that. That is the default mode network. The brain goes into sort of a default, if you will, a resting state. But on the other hand, when you are concentrating on, let's say, solving a mathematical problem or composing a speech or composing music, you have different parts of the brain what are called task mode networks. So when we are engaged in tasks, when we are going about our day-to-day business of solving our day-to-day problems, we kind of suppress the inner workings of the brain, namely the default mode network. But if the brain becomes internally preoccupied with just worries about one's own internal conscious and subconscious phenomena, and if it crosses a certain threshold, that is what we call psychosis, and that is the overactivity of the default mode network, which is what is there in this picture. So the default mode network has been shown in a number of studies to be hyperactive, overactive in people with acute psychotic reactions. In fact, a paper by Larry Seidman going back about 10 years ago showed that. And we showed some similar things using another approach to brain imaging, that it is the default mode network overactivity that might cause psychosis. On the other hand, people with chronic psychotic disorders and other chronic mental illnesses, including dementia, they may have an underactivity of the default mode network. So whether we prescribe a medicine that actually enhances the activity of the default mode network and breaks down its boundaries with the task-oriented networks, we have to be careful as to who we are treating. Who are we addressing? If there is someone who has active psychotic symptoms, it seems probably not a good idea to give drugs that break down those default mode network boundaries and make them even more diffuse further. And if I can share this other slide, this one actually shows the effect of one of the psychedelics on default mode network. Let me see if I can find that here.
I appreciate the perspectives on neuroanatomy, Dr. Keshavan.
Let me finish showing this one. Let's see here. Sorry about that. Okay, well, while I find that, go ahead and say what you have in mind.
Thank you for giving me
Yeah,
permission, Dr. Keshavan.
yeah.
I wanted to respond specifically to what Dr. Kim said. I think a lot about the ways in which that we are not there yet as a form when we're thinking about like offering psychedelics as a clinical service, as offering it as a clinical support, largely because I don't think that we're even there with cannabis. I think that cannabis as a industry, I have appreciated the ways that we've approached legalization from a harm reduction based standpoint. When we think about sort of the capitalistic interests that come into it, when we think about like the inequity and who is benefiting most from that industry, when we think about like who is still like in jail for nonviolent marijuana charges, it's primarily Black and brown people. So like when we think about psychedelics and the rollout of that in a clinical setting, I think we really need to be intentionally thinking about that, because if we're saying that like white clinicians with PhDs and clinical certifications can make money off of traditional medicines that have been used in indigenous communities for centuries, and that the Black and brown people who come from those communities who are like largely being marginalized by a larger system don't have access to those medicines or access to have agency in how their community has interactions with it, then we're creating like very large racist classist systems that are excluding the people who innovated these practices.
Okay.
Absolutely. Yeah, that's like some of the huge topics in this space.
Great.
Yeah.
So let's, there is one other aspect of neuroscience that, I want to raise and clarify for the purpose of this audience. We heard about the two kinds of brain networks, one that is focused on the inner workings of the mind, like the subconscious, which is the default mode network, and the network, what we call task-oriented networks, which are focused on day-to-day activities. What might happen with psychedelics and what might happen with psychosis might be an expansion of the activity of the default mode network. But there is another aspect of neurobiology, which Dr. Henner alluded to, which is about serotonin. It looks like, most of the drugs which we classify under psychedelics have one or other effect on serotonin 2A. But there is also glutamate. Drugs like ketamine, which really block the glutamate receptors, and PCP also have psychedelic effects. Dr. Henner, do you see any importance of integrated activity of the serotonin and glutamate neurotransmitters in explaining how we can understand psychedelic effects?
Yeah, I mean, I'll say I find that speaking too broadly about what a given neuroreceptor does is a mistake, because serotonin activity in one part of the brain is going to do a different thing from another part of the brain. We really don't yet have a firm grasp on how that one building block leads to the others, the activity of a drug activating serotonin, for instance. So I will say we do know that ketamine actually, there was a paper that came out pretty recently, within a month or two, that did a good job of examining how depending on what dose of ketamine one receives, that there is variable effect. So we've talked a lot about default mode network. There's another important network called the salience network, which has a lot to do with, how important you find a given stimulus and is heavily involved in proprioception. And so at lower doses, ketamine has disruptive effects on the salience network that is thought to underlie the quality of physical dissociation, or conscious separation from your proprioceptive physical self. Whereas at higher doses, it has more disruption at the default mode network, where you can have, for instance, ego dissolution. And so there does seem to be a converging effect on, this. I will say, by the way, ketamine is classically discussed as an NMDA receptor antagonist, but has activity at like a huge number of receptors in the brain. Like you name it, it touches on it. Endocannabinoid, opioid, all sorts of stuff. It's a broadly acting drug. But even just the glutamate effects, there does seem to have some converging kind of network effects on the kinds of things we're seeing with the serotonin. So I'm not sure if that gets at your question exactly, but that's the way I connect these ideas.
Okay, thank you. So let's get on to the next question that I had on my list. To some extent, we have touched upon it already. Dr. Kim pointed out the relationship between psychosis and psychedelics, which is of particular relevance to this audience. So there are questions that are of importance to the clinician as to what is the causal relationship between the different kinds of psychedelics and psychosis. And Darlene mentioned the possibility of even a single use of the drugs, and they can create a memory, and the memories can come back, and they may be perceived as psychosis and so on. So what is the causal link between psychosis and psychedelics? And is there, so that they will then lead on to the question as to the therapeutic value in selected patients, if any. So Dr. Kim, do you want to take that on?
Yeah, sure. So I want to make a couple of clarification first before jumping into this topic. And then I realized one, that when I mentioned the risk association between psychedelic use and psychosis, I'm not really talking about that acute intoxication effect. I'm really referring to prolonged psychosis, meaning by historical definition, like psychosis lasting more than 48 hours. And the other, I have some other thoughts that I wanted to clarify, but like it disappeared. So like, if I remember, I will mention. But in terms of the other one was the causal relationship. So I want to clarify. The state of the evidence on this topic is not at the level of talking about like causal relationship. We are trying to address the question of the correlation association, and that's kind of where we are at. And even that, the field we've been facing a lot of challenges addressing that question. But we can start talking about the current research protocol in this current era. So if you look at the protocol of the psychedelic clinical studies in this contemporary era, then you will find two safeguards that are widely accepted by, if not all, most of the psychedelic research studies. And those are, first one is the exclusion of individuals with either personal or family history of schizophrenia, some sort of psychotic disorders or bipolar disorders. And the other component is a pretty robust amount of safeguard that's been provided by providing rigorous psychological support before, during, and oftentimes even after the administration of these compounds. So when we talk about these promising results that are coming out about these compounds in terms of for many different kinds of psychiatric conditions as well as substance use disorders, we are not really talking about the efficacy of the effects of these compounds by itself. We are talking about the model of this sort of package that's being delivered with the name of a psychedelic assisted therapy, meaning we are providing psychedelics, but it's been provided along with rigorous psychological interventions and support. And that's a package, and that's being the product and the sort of the study main target that's being studied by most of the studies, except some of the recent compound study that's being studied, which is mainly trying to look at just compound itself. So I want to make that distinction because that is important. Earlier, I think somebody mentioned the importance of a set and setting, which I think it is a very crucial concept because it's very possible, the reason why those components are important is because they are closely related to the concept of psychological support that's been delivered during the research protocol. Then why do we have so that is that. But in terms of exclusion of individuals with a personal or family history of a psychotic disorders or bipolar disorder, why do we do that? Really, that protocol is coming from this hallucinogen human research guideline that was published in 2008. And that was written by the research group at Johns Hopkins, which is one of the leading academic institution, that's been sort of leading this this second wave of psychedelic research, right? So, and in their protocol, they list a bunch of different kinds of guidelines and safety sort of considerations to conduct this kind of study safely. But in their paper, they specifically state that individuals with either psychotic disorders, individuals with the psychotic disorders, such as schizophrenia or bipolar disorders, they are, quote, the most important conditions to exclude for ensuring safety while conducting this study. That's what they state exactly. Then how they came up with this kind of a strong statement. Partially, yes, it might be coming from reflecting sort of that, the clinical consensus, the coming from the clinical experts and professionals who were working in this field and working with this patient population. But at the same time, good portion of it is coming from this historical evidence and literature that we have from back in 50s, 60s, and 70s. So the kind of, sort of the well-known aspects of the story, psychedelic history back then is like, there is just a huge amount of attention that was given. A lot of research was happening looking at these compounds of potential therapeutic benefits for different conditions, including mainly with alcohol use disorders and mood disorders back then, along with its facilitating role for psychotherapeutic process. These compounds gained a lot of attention from psychiatric, clinical, and research communities during that era. But the problem was that it didn't end there. What happened with the promising results coming out, media sort of giving attention, these compounds started escaping research laboratories and also clinical practice and started to become widely used in the community, oftentimes in unsupervised settings with no safeguards or regulations around. And then subsequently, the society started to see increasing number of psychological complication cases related to psychedelic use. And then the sort of papers that started to come out, and there were a number of different kinds of complications, but among them, the greatest concerns, the ones that got one of the complications that got most attention was prolonged psychosis. And there were a number of papers written addressing these side untoward events. And then there's this researcher like Sidney Cohen, who was one of the very much like initial pioneering researcher, psychedelic researcher back then. And over time, he became increasingly more vocal about his concerns about this trend of the compounds like basically like being used like in a casual manner in the community. And it really speaks about the importance of more of a rigorous risk management while handling these substances in the community and also in the clinical research settings as well. And in fact, he wrote a paper that was in like in 1960, describing different kinds of adverse events and all, including prolonged psychosis, and what are the ways that we can implement to prevent or minimize such events. Which has a lot of sort of there is which I think it provided a pretty good like informed foundation for the Johns Hopkins group developing this research protocol later in 2008. So along with that paper, there were a number of papers reporting prolonged psychosis cases. As you can imagine, the research sort of methodological rigor was not really at the like today's standard. And yet, if you look at those papers, actually, it's very informative and describing all different kinds of events. And there's a pretty large scale of survey studies. They did, the group, like I think that there were two, which was a very interesting kind of to see and read about all of these different events, including psychosis as well. So that's what we know from the history. And then now fast forward today, now we are in different situation because the contemporary research studies, they are excluding individuals with either personal or family history of family up to second-degree family members who have these kind of conditions, right? So there are efforts trying to address this question. However, it's been pretty much done in some sort of the naturalistic study design. What that means there is just the innate method, like a great amount of methodological challenges there. So the bottom line is, we are not even talking about causality. That's like we are not there like far away. But even in terms of looking at the correlation between psychedelic use and psychosis, prolonged psychosis, really, it's the landscape looks the research findings, it's been very inconclusive, and it kind of makes even like sometimes even contradict each other. And yet, if we look at more of a granular level, which is the reason why I talked about earlier, like the importance of considering that heterogeneity factor, there has been some meaningful development. One example was the paper that came out earlier this year from JAMA. It was a paper that was done by a Canadian group looking at the individuals who had emergency room visits related to hallucinogen use. And then they looked at the risk of being diagnosed with schizophrenia spectrum disorder within 3 years from there. And then they made a comparison to the general population in Ontario state in Canada. So based on what they found was the group who had some sort of challenging experiences related to hallucinogen use that required emergency room visit. They had 21 times more than 21 times greater risk of being diagnosed with schizophrenia spectrum disorders compared to general population when it was adjusted by age and sex. When they did more of a rigorous adjustment with a comorbid substance use and mental health care conditions, different kinds of mental health conditions, still there is a significant level of correlation, even though it was less. I believe it was around like a 3.5 times greater risk compared to general population. So that's kind of like what we know so far. But if we are just looking
that
at the
to me seems like a fairly convincing evidence that
yeah.
Exposure to psychedelics is associated with a higher risk of psychosis. So clinically, if you have a young person coming to your clinic and say, I want to try this, and I have availability of psilocybin from somebody, and would you be okay with it? What would be your answer? I'm like, any of you
Well,
panelists, please answer that.
Cage, the report that psilocybin inducing psychotic symptoms that are mostly, please, anyone if no have more information or new information, is basically with people who take higher doses than normal. Usually the research, they do it between 20 and 25 milligrams of psilocybin, who is really pure, no? But the one we have more reports are for people who use dry mushrooms, and they don't kind of measure, no? Or there's some
So
studies where
dose is important, is what you're
dose
saying.
is so important. For instance, one of the studies mentioned somebody was taking 150 milligrams, which is roughly 6 to 7 times higher. 150 milligrams of psilocybin 3 times a week for 2 weeks, and then become very psychotic. The one that I mentioned, other group, everyone was with high dose.
So would you say then to this patient, it's okay to take a microdose, but not a larger dose? What would be your response?
If someone who have a family history or so, if I am a researcher, I want to do research, I will try just a micro dose to see what happened. No, moving between 10 in case it's justified. For instance, not for recreational, but history of depression, severe anxiety, I can give it a chance, but it's too close. Family history, probably not. But in case we want, in terms of research,
But he already has a psychotic disorder, which is still somewhat symptomatic.
probably ethical not. The ethical way I cannot do it.
I'm
But in
just trying
terms
to
of research,
push.
probably prove it
Yeah.
with.
But
I
on the
would
other
prove it.
hand, there might be someone who who you're seeing only for an anxiety disorder, and there is no family history of psychosis. Maybe some depression as well, but no psychosis. Would it be okay to say yes? He listens to your advice and really respects your advice. What would you say?
I have some points on some of these subjects, and I'm trying to remember them all because when people speak for so long, I forget all the points that I want to say. And I have so much to say. One about what Dr. Jung Kim was talking about, and I wanted to say that respectfully, just because there's a peer-reviewed article done on the subject of our traditional medicines back in the 50s or 60s or 70s doesn't make it that now it's acceptable. We have been using these medicine in our ceremonies for over centuries. And there is that part where they say, okay, who is allowed to participate or who can receive, the medicine? And for my experience and in my tribe, everybody, besides women when they are pregnant or when they're on their moon cycle, their menstrual cycle. So everybody is allowed to participate. There's not one person that is excluded. So if your idea of someone who's already have a history of psychosis long term, they would not be excluded. And I understand that there's a level of, well, the peer-reviewed journals back in 2008 say they shouldn't. Who says? Who says? This is something we've been doing for centuries and have never had issues with it. And it seems like nowadays more indigenous people, and you want to say shamans or bejiques or medicine people, medicine keepers, have had to go more underground, right, with their communities to offer, these ceremonies in settings where they will not be, punished, sent to jail, and all this other stuff. One of the things I wanted to also discuss was the aspect of when we say that if a patient comes into your office and whether they have a history of it or not a history of it, and they ask you, do you think it's a good idea if I use psychedelics? If you as a therapist do not have the research, the experience, I would not say no. I would say, let me refer you to someone that does have that, right? Don't exclude them or make them feel that this is not acceptable or accessible to them just because.
Yeah, no, I hear
Right.
your point, and in fact, consistent with what you say, there are some people. In fact, I have one of them who have already made up their mind to go with psychedelics anyway. But they are telling us, but our job ethically as their clinicians is to make sure that they are safe, even if they go ahead and do it anyway. So, Darlene, you mentioned the importance of setting and the mindset. So, let's say there is somebody who wants to use a psychedelic and has already come to you, and we have talked to them, and so we want to minimize risk. So, maybe you can tell us about what are the aspects of the setting and the mindset that gives the best results.
Number one is that the facilitator actually has experienced with the actual medicine. So you cannot provide a drug or a medicine if you don't know what it does to your own body. How could you facilitate usage if you don't know what it feels like to yourself? So are you just allowing them? I don't know how this works in a clinical setting. Are they laying down and you're there and they're telling you I'm experienced this and that, and what do you do? If you've never experienced that, do you diminish what they're seeing? Do you just take notes? You know what I mean? There has to be some kind of active participation
Okay.
in these settings, and one of them being that a communal sense, right? You're making the medicine together, you're singing over it, you're praying over it, you're coming together as a community, you know what I mean? You're feeling safe, you're with people that are also there for you. And so it's not just you experiencing it, you're also part of it, right? And there is a level of, once the ceremony is over, you do have to follow up with the person. You do have to follow up, especially here in
Will you follow up with the psychiatrist, treating psychiatrist as well? Because this is someone who is under care of another psychiatrist, and you are helping with the traditional medicine. And what's the nature of communication between a traditional healer and the psychiatrist in such situations?
I think it's the educational PhD doctor education that the Western sense has said, okay, this person now has a doctorate degree, so this makes them better than someone who is a traditional healer.
No,
for
I'm not
60
saying the
centuries.
comparison. It's the question of communication.
Okay.
Would you
So
say that, if I had a patient that had a psychiatric problem, and then the patient was also seeing an endocrinologist for the diabetes, I would like to communicate with their medications and make sure that they're all on the same page. Would
My
you do the same thing?
my next
absolutely.
my
Okay,
question
that's
would
important to know.
My question
Um,
as a follow-up then, Dr. Kashavan, would be like, are you going to be paying this traditional healer to be part of the clinical team? And are we reimbursing them?
No, the paying is a different issue. We are talking about, an integrated care in which the patient is safe and is getting the best benefit. So let me turn to Dr. Henner, who has more also experience in this
Yeah,
kind of a
I mean,
potential interaction between.
we're not paid
Yeah.
for like collateral calls. I mean, that's rarely billable. That's just part of, helping in medicine. Um, the the piece I wanted to respectfully, gently push back on Dr. Flores is your comment that we've never had any issues. That's really the purpose of the randomized clinical trials, is to investigate whether or not a given modality, whether it's the kind of healing ceremonies that you facilitate or any other intervention,
Sorry, say it
is
again. His brother's doctor.
Dr. Harold, I think you unmuted yourself. So the idea to investigate whether that approach is truly without issue, and I know that the culture, your lineage has used these effectively for a huge number of people, but I worry that it's a bit of a miss to say that if used in the way that you have experience with, there's never been any problems and there won't be any problems. And I think there really is some utility in going through a rigorous investigation.
So when you say investigation, you mean putting it down on paper and writing a research article for your peers to understand it, correct?
No, I'm not trying to own it. I'm trying to say that there's utility in looking at what are all of the factors that come into a particular intervention and what are the outcomes of that. And there are many different ways to go about it. There are many different ways to study something. There are descriptive ways to study things. There are randomized controlled trials. There's lots of ways to go about this. And they have risks and benefits, all of them. But I think that there is use and utility in applying a critical thought process to the question of, you know, what's going into this, what's coming out of this, and what can we learn from that?
So I think that's what the issue is. You're trying to see it as an outside to control instead of seeing it in the inside out. And I know that has to do with the medical model that you chose to use in your everyday practice. As far as, are there risks? What do you mean by risk? Will they stay in a psychosis state? Is that what you mean? Is that what you're trying to say, that would be a risk? Would they be in a prolonged psychosis? Is that what you mean by that is a risk? Like, I'm trying to understand what
Yes,
the
that indeed is what we are talking about, because we are a group of people. This consortium is about taking care of early course psychosis with the best outcomes.
right.
So if psychedelic drugs are likely to create a negative outcome, we need to understand that and prevent that.
And
So
and
so we have
and
addressed that, and
not just psychosis, but suffering. I mean
yeah, exactly, yeah.
that people come to us sometimes and they say, I did this thing and now I'm suffering more on a moment to moment, day to day basis. And it doesn't really have a lot to do with, whether you agree with their conceptualization about what's real and what's not, so much as they're coming to you, they're saying, I'm suffering, please help. And so we want to know whether these substances have a higher risk of perpetuating substances in some kinds of people.
Right, and so I feel like you guys use a lot of times the DSM-4 revised to put different disorders into that book, and then based on these symptoms, that disorder is now, the diagnosis. And so a lot of those things that you would consider not norm are put into, the DSM-4 revised. So, for example, I don't know who it was that spoke about it when they said,
So I think we are getting a little bit off the topic at this time.
well,
We
I was
only have
talking
about
about the
7 minutes left.
yeah, the
Yeah,
hallucinations and the speaking to the spirits and the ancestors. To someone that's never experienced that would say, "Oh yeah, that's definitely psychosis," or that's
no. You're absolutely right.
Oh,
So it is an important goal of the clinician would be to distinguish between what might be culturally understandable phenomena from
absolutely.
actual psychosis. Yeah, that is a completely accepted point. So I
Correct.
think we have addressed the issue of the psychosis risk to the extent that this controversial literature can allow. But let's end with maybe a brief look at what might be the benefits that psychedelics might hold for the future of psychiatry. There's a lot of interest there, and also some successes and some failures recently. And maybe, Dr. Henner, you could comment on it, as to what do you see if you had a crystal ball as
Yeah,
to whether psychedelics will become part of psychopharmacology in the years to come.
I'll try and keep it brief. It's a big question. I think that psychedelics have a lot of potential to uh, to to shift perspective for people who need a shift in perspective. I think that they engender experiences that are oftentimes transgressive in the way that people come away from them and interpret them, transgressive against power structures and dogma, whether we're talking about political or religious kind of worldviews, that these substances engender experiences where people come away questioning some of these structures. And therefore, I worry that the use of these substances will be repressed, especially in our current political atmosphere, which seems to highly value control over these sorts of power structures and narratives. So I think they hold a great deal of promise for a wide variety of kind of flavors of suffering. And I worry that if they are to be implemented broadly, that we are going to see a lot of pushback because of the kinds of conclusions people draw about the way they want to live and the way they want society to look after using them.
Thank you. Other panelists, a quick comment on this
Just
issue, on the future of
okay,
psychedelic pharmacology.
Just
Yeah.
briefly, going back and putting a little bit together what Vera and Darling mentioned too, and all of us, ideally, this is not is in terms of being synthesized as a psilocybin, is something new for us, but it's nothing new. It's people use it here in the 50s, 60s, and it's in our countries for, I don't know, thousand millions of years. But but the way they work and the cultural way is the healer, the medication, and the setting. No, all these three go together, and they got the results. The ideally, if we can preserve that, no, in some way, the settings, I think it's the healer wanna be now the provider. Could be the doctors, could be anyone. The doctors, the nurse, all this together, no? But if this preserved in the whole thing, and we can get the right doses, I think there is too much to know. There is, you know, some, but not so much.
Okay. All right. So we have a couple of minutes left. I'll take these 2 minutes to summarize the key points that we learned in this discussion. First of all, there is a lot of excitement in psychedelics as a class of compounds, but the field is very complex because the psychedelics are not one thing. There are multiple types of psychedelics and multiple mechanisms. We're beginning to get a superficial understanding of what they do to the brain. They certainly, by the meaning of the word psychedelic, it is like mind expanding or mind revealing kind of medicines. They open up some parts of the brain that are normally not available for our consciousness. And so that may have its benefits and its risks. The risks in regard to psychosis are fairly clear cut. And so one needs to be cautious about advocating their use in individuals who have had a clear-cut psychotic disorder. But in others, there would be probably value. And here, it may be in a matter of a collaborative partnership between indigenous healers and the medical profession to develop models of care that will lead to reduce suffering in this broad range of individuals who might benefit from it. So I think that's the last point. And I want to thank all of the panelists for